Today we are going to discuss about the second degree heart block or second degree AV blocks. There are two types of the second degree AV block, second degree type 1 and second degree type 2. There are two types of second degree type uh, atrioventricular block. Type 1 is known as Mobitz type 1 or the Wenckebach phenomena. And second degree type 2, it's simply known as the Mobitz type 2. Second degree Mobitz type 1, also known as Wenckebach phenomena. And second degree type 2 is simply known as second degree Mobitz type 2. What are these Wenckebach phenomena and Mobitz? Mobitz type 2, also this is Mobitz type 1. These are name of the two cardiologists or the scientists. In 1906, Mr. Wenckebach, he actually described a type of a heart block which we today known as Mobitz type 1. And Mr. Mobitz in 1924 described both these types. They were then famously known as Mobitz type 1 and Mobitz type 2. Keep in mind, this is happening almost 5 years after Einthoven's actually invented electrocardiogram in 1901. So let's see where the problem lies in the second degree AV block. As the name implies here, every problem is rooting from the atrioventricular node in cases of the AV nodal blocks. Where is actually AV node? As the name implies, atrioventricular node is located at a junction between the both atria and the ventricle, and this acts as a doorway between the atria and the ventricle when the impulse is to be transmitted downwards. This is the only place where impulse passes from the atria to the ventricles. Otherwise, these are the fibrous tissue which divide the atria from the ventricle and normally doesn't let the impulse pass from atria to the ventricle. So this is the significance of the atrioventricular node. And normally what happens when the impulse is being transmitted from the atria to the ventricle through the AV node, atrioventricular node delays the impulse transmission for a very brief period of time so that there should be a time interval difference between both the atria and the ventricle, because the atria, when it pushes the blood downwards into the ventricle fills with the same blood which was a second or a fraction of second before in the atria, and the same blood is thrown to the rest of the body. So the nature needed to produce or have a delay between these two filling and emptying. So this AV node generates that brief delay in the impulse transmission between the two atria and the ventricle. And on the ECG paper, we know that very time when the impulse is passing from the atria to the ventricle as the ST segment, as the PR segment, not the ST segment. PR segment is that very time when impulse is passing from the atria to the ventricle through the AV node. What is the definition of PR segment? PR segment is from the end of the P wave to the start of QRS complex. And it is a part of the PR interval. What is PR interval? PR interval is from the start of the P wave to the start of QRS complex. So this is a brief introduction of AV node. On the ECG paper, this is PR interval from the start of the P wave to the start of QRS complex. This is P. This brief downward deflection is Q. This upward deflection is R, and this second negative deflection is S, and this is T. So PR interval is from the start of the P wave to the start of QRS complex. And the normal PR interval is actually one large box duration or 5 small boxes duration, or it's a duration of 0.20 second. This is the definition of normal PR interval. So what happens in second degree AV block? Mobitz type 1. Mobitz type 1. Now I will draw two ECG tracings. One will be normal and the other one will have a very a small difference from the previous ECG tracing, and then I will point out the difference between the two and tell you what it is actually. If you look at this ECG, okay, this is a normal ECG tracing where P wave is present before each QRS complex. PR interval is less than one large box, or less than 5 small boxes, or less than 0.220 second, and it's a nice smooth tracing. Now let me draw another tracing and then I'll ask you, can you appreciate any difference between the two? So if you try to focus on this area, this PR interval is equal or regular in all of the complexes. But in case of the second tracing, if you actually again focus, this is one PR interval. It's gradually increasing in duration, and after third or fourth beat, there is a missed QRS complex. It was supposed to be a QRS complex here, but P wave could not be conducted downwards through the AV node. And up till now, we actually know this phenomena, that when the P is conducted downwards from the AV node, ventricle has to respond by generating a QRS complex by its depolarization. So when the P could not be conducted through the AV node, then it wasn't responded by the ventricle in the form of the QRS complex. Again focus here. PR interval is progressively increasing in duration. From 1 to second it's more, then it's going lengthier. Then after third or fourth QRS complex, there is a missed QRS complex. This phenomena is known as Wenckebach phenomena. This was described in 1906 by the Mr. Wenckebach, who was a cardiologist of that time, and this phenomena was named after him as a Wenckebach phenomena. But Mr. Mobitz also described this phenomena separately in 1924. So this is also known as Mobitz type 1 second degree AV block. What happens in the Mobitz type 1 second degree AV block, that now the AV node is getting diseased. It's allowing the first impulse from coming from the atria to the going to the down to the ventricle in a normal period. To the next impulse, it delays a little longer than the first one. And the third is delayed even longer than the second one. In this way, the refractory period increases, and the fourth one is altogether denied the entry through the AV node. It cannot be passed downwards, so ventricles will not respond by generating the QRS complexes. So this is a simple understanding of the Mobitz type 1 second degree AV block. This is not supposed to be as dangerous as the Mobitz type 2. Why? Because, for example, we are dropping a pulse after every third or fourth pulse. And if someone has got a heart rate of 80 beats per minute and the person is dropping the beat after every fourth beat, patient wouldn't be missing that much of the pulses going downwards. So the pulse generated by the heart will be around like 55 or 60. This pulse rate is enough in the number to generate a better blood pressure. So most of the time these patients are not in a critical state, but diagnosing type 1 second degree AV block or the Wenckebach phenomenon on the ECG is important because it may be associated with the myocarditis, with inferior wall myocardial infarction, with degenerative heart disease, especially degeneration of the AV node, any fibrotic disease of the AV node, sarcoidosis, etc. It may be associated with certain drugs. So this is always very important to diagnose second degree Mobitz type 1, also known as the Wenckebach phenomena. You will on the when you feel the pulse of the patient, you will feel a missed pulse after every third or fourth pulse, and it would be a regular phenomena. You will be missing a pulse after every third or fourth beat, and if you count the number in 1 minute, that goes around like 55, 60 something, and the blood pressure will be normal. So patient hemodynamically are stable, and we are only are upset by hemodynamic instability. Whatever condition of the heart brings down the hemodynamics of the patient, raises the red flag. So this is one of the benign condition as we understand, but following it, trying to diagnose the associated problem and then dealing with those is of utmost importance. Let's discuss type 2 second degree heart block, which is simply known as the Mobitz type 2. So what happens in the Mobitz type 2 second degree AV block? Now the AV node has become more diseased. It starts behaving more like a mad dog trying to bite every other person. So now there will be no change in the PR interval. There will be no progressive lengthening of the PR interval, but every now and then, uh, it can be after every single normal QRS complex, there can be a dropped beat. It can be after two QRS complexes that there would be a dropped QRS complexes. Now, AV node is allowing one or two impulses to pass through it normally, and it then stops the next one. It becomes quite an haphazard phenomena now. Now this is getting very sinister because now the number of the dropped pulses or the number of the dropped QRS complexes will be more than 30, 40, and the heart rate can drop to less than, like, for example, 30 or 40. Patient can be hemodynamically unstable, and this can be a very serious problem. So Mobitz type 2 second degree heart block is a very important and critical event happening in any patient, and because of any reason. It can be because of the myocarditis, again because of the myocardial infarction, especially inferior wall MI. It can be because of the severe electrolyte disturbances. It can be because of the AV nodal degenerative diseases. It can be because of the medications, especially the one which block AV node. So any one can cause this thing. So let's see what's happening in Morbid's type 2. That now this AV node and bundle of his may be diseased. The disease of the AV node, take the AV node as a patient. The disease of the AV node can be in the head or in the neck and the thorax. It can be high lying in the AV node, it can be low lying in the bundle of His and Purkinje system. It can be the milder one, it can get the dangerous one, and it can convert into complete heart block at any moment. Now, what's happening? That AV node is more diseased, and it is allowing, for example, the impulse generated by SA node going to the atria, causing P wave formation by the atrial depolarization. One may be allowed to pass through it down to the right and left bundle branches and the Purkinje system and generate the QRS complexes. But the very next can be stopped. It can allow two impulses to pass through it and it can stop the next one. So if I draw here the normal ECG and ECG of second degree type, Morbid's type 2, it would be something like this. This is the normal one. So what's happening here? AV node is allowing all of the impulses coming from the atria, which generate P wave by the atrial depolarization, to pass through it, going downwards all the way to the bundle branches and the Purkinje system, causing the ventricular depolarization to generate QRS complexes. And what's happening in case of the Morbid's type 2? The phenomena goes like this. No change in the PR interval. This is P, this is QRS complex, this is T, but here you see something happening. So now what's happening? This impulse was allowed to pass through the AV node and it generated its QRS complex. But this P wave was not conducted through the AV node. So it never went down to the ventricles to cause the depolarization of the ventricle. And there was supposed to be a QRS complex here, which never happened. And again, it allows another P wave to be conducted downwards, but the next one is stopped and doesn't allow to pass through the AV node. So this time around, in second degree type, Morbid's type 2, AV node is more problematic. Now this problem needs to be fixed, because at any moment, without even any sign, this second degree type 2 can convert into the complete heart block without even the escape rhythm from the ventricle. So patient has the risk of being dead at the hand of this monster. So it is always better that whenever you find a Morbid's type 2 second degree block, go for the temporary pacemaker if the arrangement of the permanent pacemaker are not there on the table. Otherwise, this patient will ultimately require pacemaker. Because if you don't put the patient with pacemaker, hemodynamically patient will be unstable. Why patient will be unstable? But this time around the heart rate would drop to like 35 to 40 and patients can have hypotension. Once the patient goes into the hypotension, patient will come to you in the ER or ICU with dizziness, with syncope, because patient is not able to mount this much blood pressure, patient can be in a confusional state. So before patient goes into the hemodynamically unstable condition, try to fix the problem with the pacemaker, and also try to look for the associated problem, which can be myocardial infarction, which can be myocarditis, which can be any degenerative AV node disease, which can be severe electrolyte disturbances, which can be the use of beta blockers and the calcium channel blockers all at the same time. There can be some nephropathy going on in the patient. So this is very important to diagnose it properly and fix the problem before anything goes wrong. So these were the second degree AV block, type 1 and type 2. One more additional thing, electrophysiological studies, they help to diagnose and localize the problem of the AV node disease where there is a dilemma of diagnosis. When you are not sure whether there is any AV nodal block or there is type 1 or type 2, because sometime in 2 to 1 block, when after every one normal there is a missed beat or QRS complex, you are not in a position to tell whether this is a Mobitz type 1 Wenckebach phenomena or this is a type 2. So in those situations, sometimes you go for the carotid massage, sometimes you do the vagal maneuvers to actually make the difference between the two, and you go for the EPS, which are electrophysiological studies.